angiotensin converting enzyme inhibitors. Again guys, this is like, wow, very important drug here, and one of the famous drugs that you will ever come across. Wallahi, this is very important drug, and it is why it's very important, you'll come to know later in the video. Angiotensin converting enzyme inhibitors, they are they are captopril, lisinopril, enalapril, ramipril, and acininopril. These are the angiotensin converting enzyme inhibitors. The mechanism of action is that they inhibit the synthesis of angiotensin 2. Okay, they inhibit the synthesis of angiotensin 2, and that causes decrease in peripheral vascular resistance, and that leads to decrease in blood volume, okay, and decrease in aldosterone. Now guys, how does it do that? Basically what happens is, if you look at this diagram here, sorry, just leave it anyways, or shall I okay, I'll just explain you guys. Sorry, this, my god, I don't know what are these. Wait. Anyways guys, listen, what happens here is, the nephron here, you can see the nephron here is getting supplied by afferent and efferent arterioles. When there is a change in blood pressure, the renin is released from the nephron. Okay, renin is released. Renin goes, okay, circulates in the blood, and from the liver there is angiotensinogen which is getting released. Angiotensinogen is the renin then acts upon the angiotensinogen and convert it into angiotensin 1. Okay, angiotensin 1. Angiotensin 1 then goes into the right hand side of the heart, into to the pulmonary circulation, and these pulmonary vessels, the endothelial cells, has ACE enzyme. ACE enzyme. These ACE enzymes then act upon the angiotensin 1 and convert it into angiotensin 2. Okay, these angiotensin 2 then come into the left hand side of the heart, and then goes to the different parts of the body and have their action. And I told you in the previous slides that angiotensin 2 receptors are present on the smooth muscle cells of the veins and the arterioles, and here in zona glomerulosa, cortex of the adrenal gland. And not only that, angiotensin 2 receptors are also present in hypothalamus, and when they activate the receptors in hypothalamus, it produces thirst. Patient wants to drink a lot of water. And when they stimulate on the arterioles, it produces arterioconstriction, venoconstriction, increase in venous return, increase in stroke volume, increase in blood pressure, systolic blood pressure. When arteriole are getting constricted, it produces increase in diastolic blood pressure. Aldosterone is getting released when the receptor here is getting stimulated. The aldosterone then acts upon the principal cells, which is the later part of the nephron, and it produces retention of salt and water, and that causes aldosterone. Okay, and that causes increase in blood volume and increase in blood pressure. And when you give ACE inhibitors, this enzyme here is getting blocked out. Okay, and you should know that this enzyme, which is ACE enzyme, is angiotensin converting enzyme. This enzyme, when is responsible for converting angiotensin 1 into angiotensin 2. Yeah. Okay, and it also converts bradykinin into an inactive metabolite, bradykinin. Okay. Now, bradykinin, when you block out this enzyme, first of all, angiotensin 2 is not getting produced. Angiotensin 2 is a powerful vasoconstrictor. And again, bradykinin is a powerful vasodilator, and instead bradykinin level increases in your body. So again, that's another plus point, because it's a powerful vasodilators. So there is um, vein venodilatation, there is arteriolodilatation, there is no release of aldosterone. No release of aldosterone produces excretion of salt and water, decrease in blood volume, decrease in venous return, decrease in stroke volume, decrease in cardiac output, decrease in peripheral vascular resistance, no thirst, increase in bradykinin. uh, well, it has a side effect actually, because when there is increase in bradykinin in the lungs, what it does is it stimulates the nerve endings, and then when it stimulates the nerve ending, it produces persistent dry cough, and that's like one of the adverse side effect reaction. And guys, the angiotensin 2, when angiotensin 2 and aldosterone, because of angiotensin 2, aldosterone is also getting released. When their level is chronically high, they actually act on the heart, and what they do is they causes pathological remodeling of the heart. So because of hypertension, the hypertension can further produce congestive heart failure. Why? Because hypertension can produce, because of hypertension there can be chronic level of chronic the angiotensin 2 can be chronically elevated, and that angiotensin 2 along with aldosterone can produce pathological remodeling, like hypertrophy of the left ventricle can be produced. So when you give this drug, this hypertrophy, the pathologic remodeling of the heart is not just stopped, but it is also reversed, because angiotensin 2 level is getting drop out, so they no longer work on the heart, and so they no longer can produce pathological remodeling. And not only that, the process is getting reversed, and heart retains its original shape. Okay, so remember guys, when a patient has hypertension, the chances of them having congestive heart failure is actually increased, because of why? Because of these angiotensin 2 level in the body. So you give these drugs, and that actually decreases the risk of congestive heart failure. ACE inhibitors and hypertension, they are the first line hypertensive and useful in the treatment of all the grades of hypertension. Addition of diuretic increases their antihypertensive efficacy. Generally combines with thiazide. They are generally combined with thiazide without potassium sparing diuretics, because there can be significant hyperkalemia. But if you combine thiazide along with ACE inhibitors, you don't have to give patient potassium sparing diuretics, because one of the effect of angiotensin 2 one of the effect of ACE inhibitor is that it produces is it well what it does is it prevents hyperkalemia. Okay, if that makes sense, hyperkalemia is not taking place. Okay, and then it is well tolerated and safe in asthmatic patient. Well, basically what I'm trying to say here is, the in thiazide, we knew that in thiazide one of the adverse reaction was hypokalemia. Okay, and hypokalemia is counterreacted by ACE inhibitors, and the adverse reaction is persistent dry cough. Why? Because of the bradykinin level. So they are especially indicated in antihypertensives in hypertension with left ventricular hypertrophy. Then ACE inhibitor is like, whoa, super important. You can give out the drugs, because they won't just stop the hypertrophy taking place, but they will also reverse the remodeling. Hypertension with renal disease. Now this is important, because how come in renal diseases? Okay, you look at this diagram here. Yeah, a patient that has diabetes, diabetes, diabetic nephropathy basically, or hypertensive nephropathy. When a patient has diabetic, because of some pathological process, the afferent arterioles and the efferent arterioles, which is getting through the nephron, is actually constricted. When they are constricted, what happens in the glomerulus, there is increase in pressure, so there is hypertension, glomerular hypertension. So when you give out these ACE inhibitors, what they do is they decrease the level of angiotensin 2, and angiotensin 2, when they are getting decreased, they cannot act on the the receptors here, because the efferent arterioles have angiotensin 2 receptors. They cannot act on these efferent arterioles. So there is like dilatation taking place in the efferent arterioles, and blood is getting can flow more easily through these efferent arterioles. And so the the disease of these diabetic nephropathy is getting healed. In severe hypertension, may be combined with other antihypertensives like calcium channel blockers, diuretics, and beta blockers. Angiotensin receptor blockers. Now this drug is again very much like angiotensin converting enzyme inhibitors. The only difference is this drug does not block out the enzyme, but instead it blocks out the receptor here. It blocks out the angiotensin 2 receptor everywhere. Okay, everywhere, whether it's in the hypothalamus or zona glomerulosa or the efferent arterioles or the here on the smooth muscle cells of the veins. It just blocks out all the angiotensin 2 receptors. So even if angiotensin 2 level in the body is increased, it cannot work upon the receptors because the receptors are blocked. And one of the advantage of these the drugs are it does not produces bradykinin, so there is no persistent dry cough basically. The mechanism of action is that it blocks binding of angiotensin 2 to its receptor. By blocking angiotensin 2 receptor, they block all the actions of AT2, angiotensin 2. Vasoconstriction thus relaxes vascular smooth muscle. Aldosterone release thus promotes solid water excretion and reduction plasma volume. Vascular and cardiac growth remodeling is prevented, beneficial in congestive cardiac failure, ARVs, and hypertension. They can be considered as first-line antihypertensive and usually combined with diuretics. Similar indication is that of ACE inhibitors, an alternative to ACE, because there is fewer side effect when angiotensin receptor blockers are given. It's like very similar to ACE inhibitors. The only thing is it does not produce this side effect called persistent dry cough. Guys, this is my first part of the video. In the next video I will be talking about the rest of the drugs which are left, like centrally acting or vasodilators or calcium channel blockers. These drugs I'll be talking in next video. Thank you for watching and hope you liked it.